Hello. Can y'all hear me okay?
Yes, your background's cool.
Awesome. I was a little bit late because I was trying to get that uploaded. Um, Sorry about that. Um, how's everybody tonight? Awesome. You're probably gonna see, let me see if I can change this. I'm trying to figure out the best system for using two screens. I've got one tiny screen and one gigantic screen. And so we're just gonna do the tiny screen. That'll work. Let's see. Just one second, folks, and then we will get going here. And
Okay, if you're looking that far up, it must be a really big screen.
it is. I at home here I have my own little closet of a space it's like dad's space. And I got a new monitor that's like 50 something inches because I do a lot of like music production kind of stuff. And my eyes are getting bad as I get older.
Welcome to the club.
Let's see. Let me try to mirror my display. There we go. Okay. Wait, that's not what I wanted to do. There. Okay. Well, hello everybody. So most of y'all know who I am. For those who don't, hopefully you've read the novel of an email I sent out earlier yesterday, and are up to speed. But I'm Dr. Armstrong, and I'll be your professor for this course. And I'm looking forward to working with y'all this semester. And yes, I said y'all because I'm from Paris, Texas. If anybody's never been there, don't make a special trip. You're not missing anything. It's not as cool as it sounds.
It is cool. I got to tell you something. I had never heard of Paris, Texas until they're the one place that my husband could order his C8 Corvette from. They got an allocation of 2. You can't get them anywhere else right now.
Interesting.
Paris, yeah, it's very good.
Well, I'm glad we finally got on the map there. Because we tried with our 50-foot Eiffel Tower with the red cowboy hat on top of it, but
that's funny. Yeah, I love Paris, Texas now.
So I am a neuropsychologist in private practice in Wiley, Texas, and like northeast suburbs. I used to have practice for almost 10 years in Paris, Texas, and then sold that practice. And so thankfully I don't have to drive back and forth anymore. My passion really in practice is, I would say, humanistically providing evaluation services for kids and teens and adults across a wide range of really anything and everything that affects the brain. And it's kind of my dad joke to say that if it affects the brain, it's in my domain. And so in line with that, this class and the child and adolescent class are really near and dear to my heart because it's all about diagnostics and looking at the DSM-5 and understanding what we're trying to accomplish through the diagnostic system, and especially as it relates to the world of professional counseling. As a counselor, I'm an existential psychologist, and if you ask 10 existential psychologists or therapists to define that, only half of them are going to answer you. The rest are going to stare out into the stars, the expanse, the tears in their eyes. But that's just a joke. I always laugh because I'm a type 7 on the Enneagram, and if you're familiar with an Enneagram, it's a personality kind of like conceptualization model, and type 7s hate being boxed in. So of course I picked the one theory that like has no methods and like nobody really knows what it means. And it sounds like you're real smart when you say it. So like people ask me, so what do you do? I'm an existential psychologist is what I do. And then that's a good way to shut down a conversation, just so you know, with strangers.
Okay.
It works really well on airplanes if you don't want to talk to the person next to you. Just kidding. I'm always that guy that's talking to everybody. So my goal for tonight is to cover as quickly as I can, just an outline of expectations for the course, and talk through about, the schedule for teaching and everything like that, as well as jumping pretty quickly and swiftly into diagnostic clinical interviews and conducting mental status exams. And reason why I want to talk through that stuff is because as a core component of a professional counselor, and even if you're planning on becoming a school counselor, I'll say this: there's no test out there that, from a psychological standpoint, that I don't have competency to give. So there's thousands and thousands of those that I could give, but 95% of my job or my diagnostic process occurs in my diagnostic interview and the history gathering. And you can do that in a way that's therapeutic. In fact, I would say that you should do that in a therapeutic way. And it can be a type of intervention that is healing for folks, especially putting the puzzle pieces together and collaboratively in a way that makes meaning for them. So with that said, our time is short, and I'm going to respect our time. And as much as I wish that I could host class on Sundays like I used to, I'm just not ready to give up Sunday afternoons in the summertime with my kiddos, because that's our go give mom a break and go to the local swimming pool time. So and they're both 6 and 9, or not both. I have a 9 and a 6-year-old, and so they're pretty independent as far as that goes, and so it's a lot more fun. I don't have to worry about them not being able to swim. No more floaties, thankfully. Those things are hard to get off. You remember that? Like it just like gets stuck. And we would have to take like baby oil to get those things off. All right, so most of y'all have had me before. I don't think anything has dramatically changed as far as grades go for the course, if you haven't had me. But our assignments include 3 grades, and that would be your weekly discussion, weekly quizzes. Your week 1 quiz, just so we're clear, I just sent out an email not that long ago, but just so we're clear, is due this Friday, the 16th by noon. The only reason why it's due by noon is because I've got to submit a class roll, and I think they don't kick you out or anything if you're not here, or if I don't count you present, but I think they show up in the middle of the night at your house and, demanding money. I'm not sure. But after that, the rest of your weekly quizzes are due at the very end of the course. And I would strongly encourage you to not wait until that last minute. One, if for any other reason, know that I see when people do stuff because it alerts me. And if you wait to the last minute, your professor will judge you. I'm just kidding. I won't judge you because I get it. But at the same time, part of me is just like, come on. Anyway, with that said, don't wait until the last minute for that. It will really help you if you kind of walk through that stuff on a week by week basis. And I believe you've got 3 attempts per quiz, and I count your highest score. Okay. And so it's not about grades anymore, folks. I mean, you're in grad school. You'd be like, well, I really wish they would have been harder because then I would have felt more. Now, your licensure exam is going to be the litmus test. I assume you're in grad school because you're passionate about this stuff. And if I didn't have to give grades, I wouldn't, because we would just do attendance, I guess. But because we have to do something, and if we're going to have to do something, I want to make it at least meaningful. So I've written all those exam questions in a way that align pretty closely with what you're likely to see in difficulty level with the DSM-5. I'm sorry, with your licensure exams. So don't judge me too harshly if that's a bad question, because it might be an intentionally bad question or a little bit confusing, because that's what the exam questions are like on the licensure exam. I've never met one person that walked away from that thing and just like, oh yeah, I knocked it out of the park. So don't worry, you're not going to feel like that at the end of that exam. The good news is 98%, I think, of Amberton students do knock it out of the park. And so as long as, you're not the 2% that just pretends like it doesn't exist until the night before, just do your due diligence and you'll do just fine. So, but at least we can practice a little bit with the quiz questions. Same thing goes for your midterm and final exam, which I think are both open or should be open in Moodle at this point. I believe you've got 3 attempts for those. If you don't, I'll double check, but I'm pretty sure you've got 3 attempts and the highest grade counts, and they're almost exactly like the quiz questions, just multiple choice exam there. I get it that like you might want more discussion, stuff like that, and trust me, I am in the process of figuring out how to make online teaching and online instruction maximize and as close as we can possibly get to in person. And I'm very confident that we're going to achieve the best I've ever done this semester, because I've got some tricks up my sleeve with some new software programs that I've downloaded. But with that said, you're going to get the most out of this class through asking me questions. So here's what I would recommend for this course is each week you've got sections of the DSM-5 that you're going to be reading or required to read. And I would encourage you to read through those as much as you possibly can, so that when you come to class, you've got a list in your head, or even maybe written down, of questions related to the clinical content, and or just you can ask like, hey, tell us about your experience with major depression in adults or older adults, that kind of stuff. Because I've got a whole lot rattling around in my brain that I don't even know what's up there until you ask me questions. As much as I wish I wasn't a nutty professor, I'm telling you. I used to be cool, people. I used to be cool. I was cool at one time. And then I had kids, and then my hair turned gray. Then I had grad students, and it turned grayer. But my knowledge base is best, I would say, extracted through your questions. It kind of gives me a structure to get there. And so the more questions, the better. I will say this is that you're absolutely always welcome to email me or message me in Moodle. And I promise you, compared to last semester, I intend to be better at getting back to people. I did already have 13 messages today, just so you'll know, 13. And Moodle's not the easiest like messaging system. It really isn't. It's like you click on one page and it takes like 45 seconds for the next page to load. And then you type one thing and then it blanks out and then you got to sign back in. Yeah. Anyway, so if you have questions, this is the ideal space to ask those questions. But I do always love to answer questions through messages. In fact, I'd much rather spend my time doing that than just repeating myself over and over again. Please see the last email, because that's what I do a lot. But also, just as a pet peeve, this happened several times, not just last semester, but over the past 4 years. I've had a lot of people just like send me a message just saying, hey, blah, 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 like, hey, H-A-Y, like, as if we're, I don't know. I don't care about being super formal. My worry is that that's also happening to people who do care, and some professors do care, and some professionals do care. So, so let's just be mindful of how we interact with each other. You don't have to say, "Dear Dr. Armstrong, today was." You can just say, "Dear Professor, hello, good afternoon, good morning, whatever." Just don't just say, "Hey, ... did you do this?" Yeah, and I will say, "Hey, no," and then hit send. Kind of passive aggressive, but I am glad you're in the class, and we are going to learn a ton about the brain and diagnostics. And for those that are worried about, joining the camp of people who believe in diagnosing, that's okay, because you've got no choice. And I'm just kidding. You completely have a choice. My point with this class is not to convince folks that diagnostics are the end all, but I do hope to expose you to information and ways of conceptualizing diagnostics such that they can be a part of the therapeutic process and very healing. Even if you're an existentialist like me who doesn't believe in all those diagnostic labels, or type 7 who hates being pigeonholed into a certain category, I get it. In fact, you're going to laugh at this, but in 2013, 2012, when we found out the DSM-5 was coming out, I was like number 17 on the list on the petition of thousands of practitioners against the DSM-5. I was a grad student, very passionate, clearly had extra time on my hands. And yeah, I was all about like, let's get rid of diagnostic systems. And I've kind of evolved over time to where I was against it, and then I became very passionate about it. And now I would say I'm kind of getting back towards the middle ground where we'll talk a lot about this, but long story short is your DSM-5 TR is written much more so for the courtroom and for legal purposes than it is for actual diagnostic or clinical utility. If you remember one thing from tonight, that's what I hope you remember. And we'll get into that a lot more, but just know that despite it being the gold standard, it has its limitations, and I'm looking forward to the science that continues to evolve it, and hopefully it does. So
I thought I read somewhere a while back that it was the only one of the other reasons why it became important was so that the medical field could talk to the counseling field with similar terminology, because they have their own, like the F codes, right, for certain.
The ICD-10, yep, the International Classification
Is that the other
of Diseases.
reason why it might be? Or do you not really talk with medical professionals back and forth like that with those codes?
Yeah, we don't. Well, I would say like in conversation or even consultation, nobody's like nobody says, yeah, that person's F90.2. Like, but we do use the terminology. So like we would say like, yeah, that person has ADHD predominantly in attentive presentation. Um, the DSM-5 published by the American Psychiatric Association is a split off. Basically, here's kind of the theory of why, and there's many, and there's probably an accurate one out there, but the one I think is the funniest, which I think is probably the most truthful, is psychiatry. Historically, psychiatrists have been considered like the most non-doctor doctors by other doctors. So other doctors are like kind of roll their eyes at psychiatrists because like psychiatrists are like high blood pressure. I don't know what. No, I'm gonna let somebody else do that one. Like all the general medical stuff. Now that's not true necessarily anymore, and certainly all of them had to go through med school. But I would say the theory is in an effort to maybe feel better about themselves or feel more confident or just you know, in spite of that, the American Psychiatric Association split off and said, nope, we're going to make our own diagnoses. We don't care what the rest of everybody is going to do, ICD-10. And then the DSM-5 rolls around and they come back to it and they kind of integrate the two.
Okay.
So
Thanks.
they welcome psychiatrists back to the family. Somebody asked me, can I explain why in the past I was against the DSM-5? Long story short, really is because I was very, very like Rogerian and humanistic existential. Not that I'm not now, but I was mentored by an existential psychologist in grad school who was passionate about, you know, not using diagnostic labels and how damaging they could be and all that kind of stuff. And so I think more than anything, I was just kind of following along in my mentor's footsteps there. Then what's funny is because I was like that, and then I actually had a real job where I got paid at the same time, or started at the very end of that, I would say, at an inpatient psychiatric hospital, which was literally my job, was to provide the psychiatrist my best case or my best conceptualization diagnostically for acutely psychotic, acutely intoxicated people in a dual diagnosis inpatient hospital. And so I had to really wrestle through all that and deal with my conflictedness. And then, yeah, that's how it happened. Great questions. Let's talk about diagnostic interviewing and mental status exams. Let's see, I'm gonna close the chat screen out. I'm always worried. Does anybody else worry about clicking buttons in Zoom? Because it feels like every time you close a window, it could be like the last window you ever close, right? It's like, okay, now the session's ended. I'm like, no! But how do I get back? Because I was the creator, then I got to email everybody. Like I just have anxiety about that, I guess. Let's see if I can. By the way, I've got a bunch of materials already uploaded in Moodle, like PowerPoint slides, stuff like that. I intend to create new ones this semester. And if I do, I will certainly share those with you. And last thing would be just make note that we've got an optional Zoom class. They're all optional, but the very end of the class, I think on the 16th, that Wednesday, I have a Q&A with me regarding all things private practice related, practicum, internship, licensure, what's the meaning of life, kinds of questions. And I would highly encourage you to plan to attend that, because it ends up being a really good conversation that I wish, or I would say most students would wish that happened a lot sooner. But you don't have to wait until then to ask me those questions. As best as I can. If I can, you're always welcome to message me those questions too. So, couple things, and actually, diagnostic interviewing, mental status exams, and neurobiology stuff. Where do I want to start? I'm going to start with diagnostic interviewing, mental status exams, and we'll probably shoot for talking about the brain and all that stuff the next time we meet, because I've got some presentations that I'm going to be presenting on soon, and I'm going to have some updated stuff on that. So don't worry about having your PowerPoint slide necessarily in front of you, but I'm going to see if I can find the one I'm looking for. I thought it was in your week 1, but maybe I didn't upload it.
So I have a quick question, because
Sure.
I love hearing that you are going to give us some lecture, but a lot of it is dependent on us bringing questions based off of our reading to you. Okay.
Yep.
Great.
Yep. And kind of putting more of the responsibility on y'all's side of stuff to read, because what I'm afraid of, and the reason why I'm changing that is because I'm afraid that a lot of students have just kind of been relying on just the lecture rather than actually having to read, because I do answer a lot of the questions from your exams and stuff in there. But in this way, if nobody has any questions, we'll call it a night, and then I'll silently judge you. But I always say that. Everybody's like, man, Dr. Armstrong, is he really kidding? Because he says that a lot. I'm not kidding. So no, I'm just kidding. All right, I don't have my diagnostic interview notes uploaded, so don't worry about that. But let's talk about it. So diagnostic interviewing and mental status exams are not the same thing technically. The reason why I say technically is because some people would say that, well, I say some professionals get them confused a lot, even like psychiatrists. And it depends on who trained you and what you know about it. But a diagnostic clinical interview is different than a mental status exam in that a diagnostic interview is where the whole purpose is for you to gather information about a patient's symptoms, why they're there for counseling, for example, when the symptoms started, how do they describe the symptoms? In other words, like the severity of those. Do they fluctuate? The timing, as well as what they've done or tried in an effort to make things better. And I'm saying symptoms, and that's oversimplifying it, because nobody goes to counseling and sits down with a counselor and says, okay, listen up. Here are my symptoms. I feel on edge more days than not. I have difficulty concentrating 6 out of 7 days. Nobody's doing that. What they're doing is they'll come in real nervous, and if they're an extrovert, they're going to just start talking. May or may not talk about why they're there. If they're an introvert, they may just stare at you. Oddly, sometimes. That's okay. If you're an introvert, nothing wrong with being an introvert. Just remember not to stare at people. Just kidding. You can stare at people. The Diagnostic interview, though, is where you facilitate their process of providing you the information you need to arrive at a diagnosis, or at least a provisional diagnosis, using the DSM-5. I remember this was my first class in grad school, by the way, guys. This class. Yep. I had no, like I took one psychology class in undergrad, made a 74 in it. And so like I was just like, I just jumped in. I remember sitting in there like, psychopathology. I was like, what? So if you feel a little bit overwhelmed, that's okay. If you're not sure what all these words mean just yet, that's okay too. Just remember, we will review and re-review all this stuff, and you're always welcome to ask questions. There's no such thing as a bad question, unless I just got through answering it and you didn't pay attention, and then you're going to ask it again. That's a bad question. So the diagnostic interview is when you're gathering information about this patient's symptoms, while also, and perhaps even more importantly, building rapport. And I don't even like that word. Like rapport sounds like you're selling a car. What rapport means is establishing a sense of safety, trust, compassion, warmth, and a stance of active listening, so that your patient feels heard. And if you can do that while balancing the gathering of that information, that's the ideal outcome. The ideal outcome is not to be exactly perfectly accurate after conducting a diagnostic interview, accurate in your diagnosis, that is. And that's because all of these diagnoses, for the most part, in the DSM are working or clinical diagnoses. In the field of medicine, it's described as a clinical diagnosis when it's something that can be changed over time. Like a broken, arm is not a clinical diagnosis, because you got a broken arm. There's nobody gonna second guess that, right? There's no like argument on the x-rays like, yeah, that's broken. I went to med school. You pay me $4,000 to tell you what you already knew. But in our field and in psychiatry, we make clinical diagnoses based on the information that's given to us, because you can't know what's not given to you, right? But it is your responsibility to gather it in a way that is mindful of all the facts and details which might be pertinent to that diagnosis. And here's, I would say, rule number 2, I think. I'm pretty sure I said rule 1 in there somewhere. But rule number 2 is you only ever make a diagnosis, even if it is provisional, if it can do 2 things. 1, does it give you and or your patient the ability to conceptualize and understand their problem and difficulties in a clearer way, in a meaningful way? Does it affirm? Does it confirm? Does it have some sort of power in it, in its ability to say, okay, so that's what it is? Okay. Number 2, it also needs to be able to give you a concrete plan, at least for the short term, for treatment. And if it can't give you a concrete plan for like, well, now what? What should we do about it? If it doesn't give you that information, or if it doesn't give you the ability to conceptualize their problems, those diagnoses are useless. I'm getting a ton of referrals right now, and have been, for teenagers and young adults who believe they have autism, which is great that we've got an expansion of mental health awareness, but it has been challenging because there's a lot of people, for example, a lot of teens and just a lot of people out there in general, who have many traits of autism, but that diagnostic label does very little in really the overall picture of that person and conceptualizing where their challenges are, what struggles they have, and or sometimes they're so high functioning that it's not likely to help us predict, what type of treatment to do or what their prognosis is going to be. And I'll just tell you my rule of thumb on that is, even on the high functioning autism side, I only ever make that diagnosis if I suspect that diagnosis is going to lead to that person being unable to live independently and or unable to obtain work or sustain employment independently, and or complete daily activities like personal hygiene, grocery shopping, bill pay independently. If it affects those things, then yes, we might consider that label. But if it's not affecting those things, we can talk about and even use autism in general as a way to help us understand how that person's brain's processing, but I'm not going to give the diagnosis. Does that make sense? Okay. Also, I would say 2B or C. I have ADHD. I've got an ADHD brain, the neurology. No matter where I go to Antarctica, and I've got an ADHD brain. I can go to the moon. I've got an ADHD brain. If I were a billionaire and I owned my own island, where my only job was to wake up, roll over in my beach bed, watch the ocean waves crash on the shore, which is not much responsibility, despite having an ADHD brain, I would not have ADHD on that island, nor would it need treatment, because it's not affecting me functionally. So a diagnosis has to affect us functionally. Otherwise, what do you need treatment for? What are we treating if it's not affecting you functionally? As much as I enjoy the clarity of my psychostimulant, I would not need my psychostimulant on the beach. I don't need clarity to watch a wave crash on the shore, right? But here's the gray area on that front, because us counselors, we like to, especially us humanistic folks, we like the idea of personal growth, right? And we say, well, everybody needs counseling, and I agree with that. Does that mean everybody gets a diagnosis? Ooh. Not necessarily. But here's my one caveat with that, and I understand why we all in there. That's all fun. It's all fun and games until you get a board complaint for medical necessity for treatment. And you have to go defend yourself in front of the board for why you thought it was medically necessary that this person needed to be paying you money for treatment that, for what? For nothing. Okay? Which can get you in trouble. Because imagine going to the doctor and them just giving you antibiotics for personal growth. I mean, that'd be a strange, don't do that. That'd be a strange doctor. First of all, if you go to a doctor and they do that, find a new doctor. Okay. But along those lines, that's how medicine views us providing therapy to people who don't need it. So be cautious with how you approach that. There's usually and almost always a good case to make that most people do need therapy at any given point in time in their life. But just know if you don't have a diagnosis, that your argument for that is going to be a little bit harder to make should you get a board complaint. Okay? And be prepared to defend why you thought it was medically necessary.
But wouldn't that come out in the notes that you're supposed to be taking? I know that in that ethics
They would certainly
class,
investigate that.
yeah, well, because you have like your notes and then you have the notes report like on a client.
So, and that's where you get into the strategy of making not just your progress notes, but a treatment plan,
Okay.
which has to have a rationale. So you're going to write all that stuff out and think through it beforehand.
Okay.
And rarely will you have somebody that comes to you who is 100%. I say rarely. I don't think I've ever met the person that's 100% psychologically well-adjusted, which means that they probably qualify for adjustment disorder in the DSM.
Oh, okay.
Yep. That's kind of an easy, I'm not saying everybody needs to be diagnosed with that, but that's what a lot of counselors end up doing. But also be ready to provide your rationale for why you diagnosed adjustment disorder, and you need to communicate that to your patient. Can't just diagnose stuff and not tell people. That happens all the time, by the way. I get records and people are like, yeah, I saw this so-and-so, but we just talked. And then they'll say like all kinds of personality disorders and all stuff. It's like, great. I'm going to have to be the one to break it to them, I guess. They should have told them. Because
so
all
does
that
the board do random like checks, or is it just if there's a complaint, or how would you get called in front of a board? Like, what are the red flags?
It's not going to be random. It's going to be, because they certainly don't have the resources for that. It's going to be based on a complaint, and usually from a patient that's upset, or I mean, honestly, in our field, you never know. Like, I mean, we have a unique population of folks where, I mean, even it wasn't that long ago, I had a complaint that didn't go anywhere, thankfully, but from a patient that was, I thought we had a great everything. I thought it was a great rapport, all that stuff, and so you never know.
Okay.
Yep. Keep good records. And then somebody asked, was it Hannah? Is that right? Hannah Isadora? How do you make that argument going beyond personal growth? All right, that was a good question. So again, that's the adjustment side, identifying some concrete goals, because otherwise you're just a coach. You didn't go to grad school to be a coach. You don't have to go to grad school to be a coach, in fact. So if you want to work with people who don't have problems, I'm not really sure why you're here, right? And on top of that, I would say this is that there are plenty of clinical patients, folks. We have an extreme shortfall in Texas. So we need people who are clinically trained, because, I mean, I'm getting 30-something referrals a week that I'm having to turn away for counseling because we don't have any openings. I'm trying to refer out, but everybody I know is also booked out. So get your license and you got a job. give me a call. I might hire you. All right. So diagnostic clinical interviews. So you're like, well, what is that? What do you do? All right. So what you actually do is, first and foremost, after you introduce yourself, don't just like walk in like the doctor does. I went to the doctor the other day. They walk in, right? You're sitting on the crinkly chair with your little legs like dangling like a weirdo. And they walk in after 30 minutes. And you're just like, what in the world's happening? They don't say anything. They go to the corner, start typing on their computer. They don't even look at you, and they're like, all right, so what's wrong? And you're just like, oh, hello, hi, I'm Levi Armstrong. Nice to meet you. Like, don't do that. In other words, do the opposite of that, which is be a warm person, be yourself, be a human being. You don't have to be clinical. A lot of beginning therapists make the mistake of overthinking this. And that's easy to do. I did it too. But you have a therapeutic spirit about yourself. Let yourself be a human being and think, okay, if I met a counselor for the first time, would I want to just like, barely sit down in the chair or the couch, whatever it is, and then just out the gate, like rapid fire, like, okay, well, tell me about all your symptoms. No, you probably want like at least a little bit warm up. So do some warm up. Just say, hey, how you doing today? Just be a kind person. From there, we are going to introduce the concept of what's going to happen. So we're going to let them know, hey, so just so you know, in this first session today, really my approach to all this is that the quickest way for me to help you is for me to kind of get the best overall overview of all the puzzle pieces of your world and story. And though I want to hear every detail, and I think eventually we would have time to get to those things, today's time is limited. And if you'll allow me, I have a process of walking through some questions that I'd like to walk through with you that kind of help me organize and speed up the efficiency of me getting all that information. And so if you find that I interrupt you, I promise you it's not because I don't care. I do care. And we can put, we can table that for a minute and return to it. But it's because I'm wanting to steer our conversation back to that efficient process. Because again, the quicker I can get a clearer picture of everything based on the training that I have and understanding how to arrive at that destination, the quicker I can help you. That works most of the time. For people who have executive functioning difficulties, you're going to have a harder time. But that's where you get good at therapeutically redirecting people, and it just takes practice. And again, just think about it this way. People always get nervous, like, I don't know how, like, my patient just keeps talking and talking and talking. I don't know how to interrupt them. Well, how do you interrupt your aunt at the family reunion that you don't want to talk to, or that you're trying to, say something important? Probably not like, can you stop? You don't do that. You don't just walk away. No, you say, just whoa, 1 second. Let me back this up because I want to make sure I'm getting this clearly. And then you ask your question. Okay. So what do we do in the diagnostic clinical interview? We are going to ask all questions related to their history. And hopefully you've had a background questionnaire that you've let them complete. And I would encourage you to make one. I mean, I made one in grad school. I'll tell you what, I'm going to share with y'all. Would it be helpful if I shared with y'all my paperwork for my practice? That way you can see what it looks like.
That'd be awesome.
Cool. Let me do that real quick. What's interesting is way back in the day, in grad school for me way back in the day, I guess 14 years ago. I made this during grad school, and then it's just kind of been tailored to my needs over time. And so I would encourage you, don't just rely on my stuff, because mine's made for me, but you can use it as a template and make your own. It's actually kind of fun. It's a good way to procrastinate, you know, writing a paper or something, which is why I did it back in grad school. Let's see. Pretty sure this is it. Oh, I might have to down. All right, I'm just gonna have to post it on Moodle later because this Zoom wants me to download it to my computer and all kinds of stuff. I don't have it downloaded to my computer. Anyway, with that being said, I do have to be mindful of our time, and I know we didn't get into mental status exams, but we're gonna table that discussion for next time, because mental status exams, if you know how to do that, if you know how to do diagnostic interviews, like I said, that's 95% of this equation. And my goal here is to post for both you guys and my child and adolescent class some real brief videos that I have created already. And I know I've said that several times in my classes before, but I'm actually at a place now that I'm actually going to be able to post those. So, so keep an eye out on that stuff, because it'll be like 5-7 minute mini videos just covering real quickly, you know, real specific topics. And don't judge me too harshly on those, because I've used some video production software and some really cool like graphics and stuff that it's actually like a podcast thing. So anyway, it's called brain loading if you really want to know. But those should be posted pretty soon. I'm gonna try to do that once a week for y'all. And then I had one more. There we go. With our next class, I think we've got class on the
26th of June. You wrote
yeah.
it in the class schedule,
Yep.
Zoom class schedule. It's online to see.
And I turned 39 years old on the 25th, folks.
Woo! You're young.
For the first time, I'll turn 39. So we're gonna stop counting after this year. But my goal is to turn 40 next year in the best mental and physical shape of my life. So I hired a nutritionist and got my counselor I'm meeting with, all kinds of stuff. I'm gonna start running again. I'm gonna do it. All right. What questions, concerns, hesitations, Thessalonians, anything like that?
If no one else does, I'm waiting. The videos that you'll post, are they going to be embedded in week 1, week 2, like that? Kind of like these right now, you need to be reading this stuff in the DSM. And
They will be.
And whatnot. And then you have PowerPoint slides in there, which are a lot of information, which is great because you actually wrote out the detail. So we're not trying to decipher, what does he mean by this? Because you wrote it out. Okay. Those are the key things.
Which is not what you really want to do when you do PowerPoints, by the way.
It's okay. It's easy if you're not going to go over the PowerPoints with us, then we can read it ourselves.
But yeah, I will, and I'll send out an email when I post those, so you'll know that I won't just like sneakily do it. Trust me, I need some affirmation. I want y'all to be like, oh yeah, he did it.
Thanks.
Yeah. Hannah.
Can you tell us just a little bit more about the quiz, kind of what to expect in terms of format, just so we know to prepare? Because accidentally last night I just opened and I basically used one attempt and I haven't even looked at the content. I literally just clicked on it. So I just want to know, because I was just trying to see what it looks like. I've never done this format of
Sure.
so please, if you can speak a little bit about the quizzes.
The quizzes, yeah. So for each quiz, you have 3 untimed attempts. And if for some reason you missed an attempt on something, just email me and I can reopen it. Like, so if that happened to you, if you can tell me which week it was that you did it, I'll give you another attempt on it. Okay. But you'll have three untimed attempts for each quiz. Same thing for each exam, meaning that from now until the end of the semester, you can take those, and they're multiple choice. And whenever when you get done with your first attempt, if you make 100, unless you just, have a lot of extra free time, you don't have to retake it. So I'm only going to count your highest score. Okay. But you have up to 3 attempts for each quiz. And yeah, they're multiple choice. There are 5 questions for each quiz. I think the midterm final exam are about 35 or 30 questions, straight out of the DSM for the most part. Although some questions might require you to, accordingly as a grad student, do your own research outside. And you're gonna go back and forth on some of those questions. You're gonna say, "Hey, Dr. Armstrong, your right answer is not the right answer," and that's great, because you can argue with me, and that's worth points to me, because that's just effort and you're learning. Even though at the end of the day we might disagree, but if you can show me that you've done your work and you could argue a point, hey, I'll give you a point, even if at the end of the day I still say it's wrong. Does that make sense? Yeah. So does that answer your question with the format? Awesome.
Will the quizzes be under the readings and the PowerPoint information, or just from the DSM?
Those are much more so straight from the DSM.
Okay.
Yeah, because you're going to get questions like, what's the prevalence rate of OCD?
Okay.
That kind of stuff. Yeah. Yeah. But yeah, if you have questions on a quiz, please bring those questions to class or send me a message. And again, I try to give people as much flexibility as possible. At the end of the semester, I always get complaints from students saying, how terrible of a professor I am because I didn't make them have due dates all throughout the semester. I really do. I get that feedback every time. And the dean's like, "Are you really doing it?" It's like, yeah, because these are adults. So I'm trying to be flexible for you. If you have questions on that stuff, just reach out. I am very flexible. I'm not here to fail anybody. And again, if Moodle messes up on you, just let me know and I can fix it on my end. Yeah, because there's always that pressure. It's like, man, I don't want to hit submit. What does that mean? And then you hit submit twice. It's like, are you sure? It's like, I don't know if I'm sure. Yeah. Makes you double think everything. So
I'm pretty sure that the quizzes right now look like there's only 2 attempts in there. It doesn't really matter. I mean, because 2 attempts is even very gracious on your part.
Well, not, and my that's an error in Moodle because I had fixed that once before. I'll go back and fix it.
Yeah, all of them are 2, because I went and peeked at all of them already.
I spent like an hour like a month ago fixing that one time already. Moodle's weird. Moodle's weird. Right. Okay. That's the kind of stuff I do want to know though. So if you come across errors, please let me know. I mean, sometimes it's me, sometimes it's not. It just depends. But all right, folks, I'm going to move on to my next class here. Bye. But we'll see y'all in a few weeks.
I just want to introduce myself because my name is not reading there. My name is Mary Meriti, Miriti. I'm using a church a Zoom, so that's why it's not reading my name. So I mean, in the conference, this is the time of our Methodist annual conference. That's why you can hear some noises around. And just sneaked out to be able to be in the class.
Awesome. Well, welcome aboard.
Thank you.
Yeah. Well, y'all take care, and we'll see you in a couple weeks.